We move on to the next session, and we are privileged to invite the next speaker, Dr. Hilary Fernando from Sri Lanka, who will speak on the topic Novel Treatments for Metastatic Urothelial Cancer. Over to you, Dr. Hilary.
Good afternoon, everybody, chairpersons, and ladies and gentlemen. I'm Dr. Hilary Fernando, and my task today is to take you through novel treatment options for metastatic upper tract tumors. I think my colleague covered most of the basic factual details about this. And out of these, 60% of the upper tract tumors are invasive at diagnosis compared to about 20% tumors that are invasive in the bladder. And their 5-year survival rate is about 50% even in developed nations. And the treatment options, also radical nephrectomy is the standard of care. And out of those patients, 20% will have a recurrence, and out of them, again, 82% will die of metastatic disease. And lymph node dissection was recommended by EAU in 2013. That helps with accurate staging and also improves disease-specific survival. And we heard the nephron sparing options. Then we have chemotherapy, neoadjuvant, adjuvant, first line, second line settings, and then the immunotherapy with checkpoint inhibitors, then the novel molecules targeting FGFR receptors and antibody drug conjugates. So the neoadjuvant setting, 60 to 70% pathological downstaging rate was recorded, and the 5-year overall survival was 44% versus 29% having the surgery only. So the advantages of neoadjuvant therapy, the patients have T2 renal units to tolerate more toxic chemotherapeutic agents, and the subsequent specimen gives an idea about how responsive the chemotherapy was. And then the disadvantages, especially in chemotherapy-resistant patients, it delays the primary surgery, and it may increase the perioperative morbidity and overtreatment, as there is no pathologically confirmed invasive disease at the start of the treatment. Then the adjuvant chemotherapy, the combination chemotherapy with cisplatin is the recommendation, and various combinations are there. The MVAC regime with methotrexate, vinblastine, doxorubicin shows superior recurrence-free survival of 71.4% compared to gemcitabine and cisplatin. The disadvantage of this, once you lose one renal unit, the EGFR may drop below the ineligibility criteria level, and the patients may not be able to tolerate more toxic cisplatin, and we need to think about less nephrotoxic agents, such as carboplatin-based combination regimes. The problem there, the survival advantage is with the cisplatin, 15 months over 10 months with carboplatin-based regimes. So the immunotherapy, this is a new concept. So the interaction between PD-L1 ligand of the tumor cell and the PD-1 receptor on the T cell, this interaction inhibits T cell mediated tumor killing. So if we can block the PD-L1 ligand on the tumor cell, or either block PD-1 receptor in the T cell, we can induce T cell mediated tumor cell death. So there are several immune checkpoint inhibitors recommended by the FDA for first-line cisplatin ineligible patients and PD-L1 positive tumors. The atezolizumab and pembrolizumab is recommended by both FDA in US and European Medical Authority. And patients ineligible for chemotherapy, independent of PD-L1 ligand expression on the tumor, FDA approves treatment with these. So this is how it actually works. The examples for blocking the PD-1 receptor on T cells are the pembrolizumab and nivolumab. And examples of blocking the PD-L1 ligand are the acitolizumab, durvalumab, and avelumab. So if you block any of these, it induces the T cell mediated killing of the tumor cells. So The pembrolizumab is the only checkpoint inhibitor with level 1 evidence in the second line post-platinum setting derived from a prospective randomized phase 3 trial, the Keynote 045. It shows improved overall survival to pembrolizumab compared to second-line chemotherapeutic agents. And then the novel therapies, it shows that FGFR3, which correlates with T-cell depleted immune microenvironment, is there in metastatic upper tract urothelial cancers. Then the pan-FGFR targeting erdafitinib is a novel molecule. Then the other one is the antibody-drug conjugate enfortumab vedotin. So this is the evidence for erdafitinib. It shows overall recurrence response rate of 40% and median progression-free survival and overall survival of 5.5 to 13.8 months respectively. So this antibody-drug conjugate, it has a monoclonal antibody which targets surface protein nectin-4, which is expressed in urothelial cancer cell surface. And once this is combined, it will get incorporated. And this particular molecule has incorporated mitomycin microtubule inhibitor, the drug monomethyl auristatin, which gets inside and induces a cell death. So there are multiple trials, shows overall response rate of 40%, and this is how it actually works. And these are the futuristic molecules that can be targeted for further treatment options and biomarkers for response of therapies. Thank you.